Good morning or good afternoon, everyone, wherever time zone you might be in. My name is Dr. Edward Cragen. I'm a board certified medical oncologist and the first Mayo Clinic consultant board certified in hospice medicine and palliative care. And I am profoundly grateful for an opportunity to share an absolutely crucial topic about which there are many, many misunderstandings. This is not designed to be death by PowerPoint. As I proceed here, please jot down questions or issues, and I'm very happy to stay beyond the hour because we may never have this opportunity again. I am a professor of medical oncology, and I've had some other honors at Mayo, and I'm just pleased to be here with Sharon and her team. So
Great.
if I could just
Sure, Dr. Cregan, I'm going
advance.
to run through a couple Fight CRC slides, and then I'll hand over the presenters to you.
Good. Okay. Thank you.
Yeah. So super excited. The Fight CRC team is very excited to have Dr. Cregan here with us today to talk a little bit about end of life discussions that are very common among cancer patients. As we go through the presentation, I know Dr. Cregan had mentioned, please write down your questions. We'll have plenty of time at the end for question and answer. If you want to type it in on the panel on the right side of your screen, I'll be able to see them as they come in, and you can address your questions at the end of the session. Um, and if you want to revisit and watch this again at another time, we will archive the webinar at fightcrc.org/webinar. And of course, if you're on Twitter, please follow us along at #CRCwebinar. We have a number of free resources in addition to our wonderful webinar series. We have our Tabooty podcast, we have our clinical trial finder, and we have our Beyond Blue. Our latest edition just came out a few days ago. So if you haven't checked it out yet, please visit the website and grab yourself a copy. Our quick disclaimer here, the information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, please see a doctor immediately, and in an emergency, call 911 or go to the nearest emergency room. Fight CRC never recommends or endorses any specific physicians, products, or treatments for any condition. And with that, of course, we have Dr. Cregan. Really, we're thrilled to have him here. He's been at the Mayo Clinic for a long time and is really an expert in this field. He's written books and is just a wealth of knowledge. So, Dr. Cregan, we are super happy to have you, and I am going to hand you the presenter controllers now so that you can flip through your slides at your own time.
Great. Thank you.
You're welcome. Thank you.
And let me just make a plea to the audience. Please share criticisms or critiques of what I share with you, because the key concept of any speaker is to meet the needs of the audience, not to impress you with how smart I am, but to make sure we leave here empowered to make the right decisions for ourselves and our family. So let's just move on here, okay? All of this information is available in a book, which is on Amazon. It's in your bookstores. It's called Farewell. And this book summarizes approximately 40,000 conversations that I've had with dying patients and their families over about 40 years of doing this. So like each of you, when you do something repetitively, you learn what works, and you certainly learn what does not work. And I've learned from some misadventures. Let me share with you my email address, cragen.edward@mayo.edu. And I'd like to hear from you on something that you've done that works or something that doesn't work, or how we can improve this program. And Sharon mentioned Twitter, and I tweet every day with downloads and also URLs attached. So I would welcome you to follow me on Twitter. And the theme of all my tweets is empowerment, just like we're empowering each other this afternoon. So let's start at the beginning, and let me share with you how this journey started for me. The year was about 1890, and my grandmother left from Cove, which was the harbor of Cork in Southern Ireland, for America. And she was 11 years of age. Everything she owned in the world was in a pillowcase. And she spent 6 weeks at sea, and then she was dumped on Ellis Island, like many of our ancestors, spoke not a word of English, and she became my surrogate mother. She raised me. And just hold that thought for a minute because we're going to come back to that. Now, at the same time, a ship like this left the grim seaport of Hamburg in Germany. And on this ship was a 12-year-old immigrant, a young boy who spoke not one word of English, and he became my grandfather. He met my grandmother and they married in New Jersey. Now, why do I tell you this? He became one of the most prominent jockeys on the East Coast. In this photograph, he was about 18. He weighed about 130 pounds, maybe 5'7". And he became homicidally competitive and became very successful riding for wealthy, powerful families in the New York City area. And those of you who are familiar with thoroughbred racing can understand this is a very dangerous way to make a living. Now, but let me tell you the rest of the story. My grandfather did not get injured, but he had a serious problem with alcoholism. And he was unable to ride, and the family fortunes went right down the tubes. And we moved into a rooming house in Newark, New Jersey, across the city, across the Hudson River from New York. And my grandfather started to work in a foundry. So all of a sudden, the family fortunes disintegrated, and we went from the good life to living in a rooming house in Newark, New Jersey. Now, this was a photograph of me. Now, I know some of you are laughing, but when I was about 8 years of age, my grandmother told me to take care of one of the patrons who was living by himself in a rented room on the second floor of this rooming house. It was 615 Hunterdon Street, and I remember it as if it were yesterday. So what does this have to do with end of life? The gentleman that I cared for was an Eastern European, spoke not a word of English, and he had cancer of the rectum. Now you can imagine what a cancer of the rectum was like in the 1950s. And my job was to change his appliance, to change the bag, the primitive bag, which connected his wastes. And whether this was a divine inspiration, I don't know, but I did know my career would be focused on end of life individuals. So it was a blessing because I was not distracted by some other occupations. So, but the rest of the story was my stepfather. He owned a bar and two liquor stores outside of Newark, New Jersey. And he demonstrated what happens if we don't do prudent financial planning. And he demonstrates what happens if there is not an awareness of advanced directives. And we're going to drill into these issues in just a couple of minutes. And what I learned from that existence is that we make our own luck. Our being involved with this webinar right now doesn't happen by luck. You've planned for it, and we're brought together by some energy or some power that brings us all together to make life better for patients and families. Now, the rest of the story, and we can just go back here for a moment. One of the iconic performers in music is from Minnesota. It was a performer called Prince. And I just show you this because several years ago, he died without a will. And he left an estate of several $1 million. And this has been a very difficult situation for his heirs. And here's the Queen of Soul, Aretha Franklin. She likewise died without a will. So I just tell you these things, and we'll come back to the will in a minute, how important it is to do our homework on these financial issues. So what I'm talking about We need a flight plan for life. We need a GPS. We need to have our hands on the helm because if we don't take care of these things, somebody will making decisions for us, and that may not be in our best interest. The future depends on what we do today. So I would ask each of you to make certain that sometime today you think about advanced directives, because if you don't make those decisions, somebody will be making it for us. And Lord forbid, one of us is driving home today, we have an automobile accident, we are on a respirator, we have a kidney dialysis machine, we're fed intravenously, we have medicines for our blood pressure, and then the burden is on our family. How long do we continue this artificial environment? So if we don't do our homework and take charge of our own life and our own death, the decisions may not be in our best interest. Now, this is a typical cancer corridor in one of our floors here at Mayo Clinic. And the drama that's played out on these floors and in these rooms could rival any Hollywood script. We will knock on the door, and a patient will ask us, this is someone whom we've never met, Dr. Cragen, how long will I live? So part of that discussion needs to be what quality of life is important? What are the things that are crucial for that patient and that family? So getting back to the book, this is a cookbook, this is a recipe, this is a formula of the things that we need to understand because this issue is bewilderingly complicated. And if it's not done appropriately, families can be torn apart for generations. So let's just look at some of the topics in this book. We're going to be talking about how did palliative care and hospice start? Well, it started because patients and families were not satisfied to give over the decision-making process to the healthcare community. This needs to be a collaborative, interactive decision-making process where all family members can contribute, especially if the patient cannot contribute himself. We talk about the crucial importance of family meetings, and this works by having sitting around the table the key stakeholders. This is the spouse, this is the partner, this may be children, adult children, and families today are very different than they were a generation ago. We'll come back to that point in just a minute. But everybody should be acknowledged and validated when these important decisions are being made. Now, what do we do if there is a conflict? Let's suppose one of us is on a respirator. We can't speak for ourselves. And let's suppose there are 3 adult children. 2 of them said grandma would never want to live in this condition. But the 3rd adult children says, no, life is sacred. As long as there is breath and breathing, we want a full court press. What do we do when these issues arise and no one can agree? And that's also part of this discussion as well. Equally importantly, who takes care of the caregiver? There are lots of studies that demonstrate that immunologically, caregivers are profoundly compromised. Their lifespans are shortened. They are at risk for anti-inflammatory disorders. And there is a point where the caregiver can no longer do it. Let me digress for a moment. In our family, as I'm sitting here, we're dealing with a beloved gentleman who's 79 with profound dementia. And every one of our listeners has been touched by this issue. The patient's wife has a chronic bone marrow abnormality. She's 79 and she's basically disintegrating under the pressure of taking care of him. So we all need to raise the question, what are the options if the caregiver can no longer do it? And this is an issue that every one of us is in facing. If we're not facing it today, we will in the relatively short term. Now, every one of our organizations has an advanced healthcare pleading booklet. This is typically in human resources, perhaps in the business office, perhaps in the social services department. But every place has something like this. And this is one of the most important documents that we will ever read. And this is the kind of document that should be shared around the kitchen table in the light of day when people are on top of their game. And the holiday season is an ideal time to do this. Families are spread all over the world, but typically during the holiday time, people come home like chickens to roost. And this is the time to have a discussion about what do we do if one of us can't speak to ourselves? What do we do if grandpa is continuing to fade? Now, this is a typical book that we use here in Rochester, and your organizations have a similar document. So let's just briefly look at this. I feel my life would no longer be worth living if I have a serious illness and I have a number of the other developments. I can't think clearly. I can't understand. I can't recognize. So these are all cognitive impairments. If I can't recognize my spouse and my loved ones, if I can't make decisions for myself, do I want to be maintained artificially? If I lose control of my bowels and my bladder, if I'm in constant pain, if I have symptoms, are these the kind of factors that would encourage my family to de-escalate the quality of care? But on the other side, we need to recognize that there are some belief systems where life is sacred, life is respected, and there are no circumstances which would support or justify withholding or de-escalating care. So we need to be respectful and sensitive for different belief systems that have, so that those belief systems are not invalidated. When I'm not able to decide or speak for myself, I have the following preferences about my healthcare. Now, just look at these. Sometimes patients opt for treatments to prolong my life. I want everything done. I want a full court press, even if I am on life-sustaining equipment. Or I want the equipment to maintain, but to stop the equipment if they are not helping or if the burden is greater than the benefit. Or, and we need to think about this, I want to stop or withhold all treatments to prolong my life. These are not decisions that we should make in the glare of the monitor of the intensive care unit. These are the kind of decisions we should make over a Thanksgiving dinner, over some other religious services, so that there's complete clarity on we want for ourselves, not to have some other agency make those decisions. Now, this is a crucial slide. The Advanced Healthcare Directive is a two-part thing. Number one, there's a person, which is the agent. This is the surrogate to make decisions for us when we cannot speak for ourselves, sometimes called the power of attorney for healthcare. But also in particular, we also specify the kind of treatments that we want. Now I have here in front of me a legal document which shows exactly what my wife and I want. This document spells out the kind of management that we would want if we are in a situation for which there's no reasonable probability of benefit. So if it's not written down, there can be tremendous confusion among family members, and this can lead to bitterness that can go on for generations. So write it down. You can do this on the back of a napkin, on the back of an envelope. It's probably best to have an attorney involved. It's probably best to have it notarized so that there's no confusion. But I think the important thing, do it, because if it's not done, the consequences be horrific. So we're talking about an agent or a proxy. Who speaks for us? Now, in the document that my wife and I have, my wife, Peggy Menzel, she speaks for me. Conversely, I would speak for her if she can't speak for herself. But there also needs to be plan B. Let's suppose my wife is demented, she can't speak for herself, and then something happens to me. We have another family member who would act on her behalf. So this is a big deal, and if it's not done well, it can be a real issue. And we also need to spell out what magnitude of aggressiveness of treatment do we want. And in our documents, we spelled out crystal clearly, if I'm in a situation, say with my wife, if there is no reasonable probability of improvement. So let me stress reasonable probability. I do not want to be intubated, on dialysis, have a feeding tube, antibiotics, medicines for blood pressure. So this gets the burden off the family. They're not saddled with that decision because this is a heavy trip for patients to have family members do. Now, this slide shows what can happen. So we have the patient who obviously has a serious problem, and around the bedside are a number of stakeholders. Some would say, let's de-escalate care. Let's let's not continue with artificial hydration and nutrition. Others, for reasons, may say, no, we want to keep the patient going at all costs. And these can be very complicated relationships. So we need to spell out exactly what we want, or family members may be acting from a negative perspective, and they may not be acting in our own best interest. And I think this is especially important today because families are different. We have second marriages, there are mixed relationships, there are adult stepchildren who hardly see each other. So the day of Lake Wobegon does not exist anymore, and we just need to be mindful about this. Now, let me share with you a baseball story that's crucial. Several years ago, an umpire was getting up to speed on his baseball skills at the Grapefruit League, which was in Scottsdale. So umpires go through spring training much like a baseball player. He was behind the plate calling balls and strikes, and then inexplicably he started to walk to third base, and everyone was stunned. He then fell face down on the turf, had a seizure, and a massive myocardial infarction. There were several students from Arizona State University that sensed what was going on. They leaped over the fence, did CPR until the helicopter came. Traffic was too bad. He was taken to a wonderful health facility in Scottsdale. He was stabilized, but then he was flown to Minnesota where he had family. And I was on the palliative care service at that time. And you remember these circumstances as if it were yesterday. So I walked into the room. His feet were towards the door, head was towards the wall. And around the bedside was his widow, his wife, and three adult children who were baseball executives. And it was clear at this point that there was no reasonable probability of survival. And I asked the family respectively, were there advanced directives? Was anything written down? And the family was stunned. They were not aware of such a document. This was about 7 o'clock at night. Everyone was exhausted. They lived about an hour and a half away from Rochester. So we each agreed, find a motel, find a hotel, take a hot shower, get a cup of coffee, and let's regroup in the morning. The family wanted to go home, so they all drove home about 90 minutes. Then the next morning on rounds, we again visited, and it was a completely different environment. So what happened? During the night, the patient's spouse opened up a safe deposit box, which was in their den, and in that box was a handwritten note that the wife was not aware of, written by the patient. And he basically said, if I have X, Y, or Z condition, if all the experts say I'm not going to improve, I do not want X, Y, and Z. So the burden of that decision was taken off the family. We were able to compassionately de-escalate care. The patient peacefully passed away, and it was a real feeling of closure and relief on the part of the spouse and the three sons. So write it down. Don't simply tell somebody. Make sure that there's complete clarity on your wishes. Now, this is the scene that we're all familiar with. Patient has had perhaps a stroke, perhaps anoxia with no chance of benefit. Let me share with you a real life story. Over Labor Day weekend, a prominent member of the Minneapolis business community was working out in a very modern health facility. He was on an elliptic glider. He had a history of high blood pressure, a history of high cholesterol, but was feeling well. He had a myocardial infarction. He slumped to the floor. There was an attempt at resuscitation, but it did not go smoothly. And after about 6 to 8 weeks, the patient was in a persistent vegetative state. He was seen by the top neurologists in Minneapolis. He had EEGs, he had MRIs of the brain, and there was no reasonable probability of improvement, but there were no advanced directives. So the family is now pressured into making this difficult decision. What would this person have wanted if he could get out of this coma? What would he share with us? A very difficult decision and a burden that family members may carry for a lifetime. So, for the sake of our families, we need to spell out what we would want done if we were faced with one of these dilemmas. Okay. This is a normal chest x ray. Black is air in the lungs. This is the heart. And these are the ribs, and everything looks fine. This is a chest x ray, which shows far advanced cancer. This could be any kind of cancer, but this is far advanced colon cancer. Okay. Now, why do I tell you this? Well, this is part of my family. This is my best friend, my running partner, Peggy. This is her brother, Jack. He's a CPA. This is Mick, anesthesiologist, and this is Bob, who owned a business in the upper Midwest. They represent a third generation of individuals at risk for colon cancer. In other words, their grandparents, their parents died of colon cancer, so they are at risk. So they know they have to follow a low-fat diet. They have regular colonoscopies, but they've each agreed if they have a serious problem like we just saw on that X-ray, they do not want X, Y, and Z. Write it down, spell it out. You will save your family a lot of misery. Now, this is a painting by Norman Rockwell called Freedom from Want. And this is the traditional Thanksgiving feast. However, I think we have to recognize that families today are different, they are complicated, and we need to be respectful for other patients, other people's wishes when it comes to these end of life discussions. And equally importantly, around the bedside, around the kitchen table should be all members who've been touched by that patient, who are part of that extended family, who are part of that relationship. No one should be ostracized or not invited to the table when it comes to these very difficult decisions. Now, let's talk about the aging process because this represents special challenges. Let's talk about Southeast Minnesota, where I live. In the year 1900, the average age was 45 years of age. Right now, the average age is 84. Of patients in their 80s, approximately half have cognitive impairment. And every one of our listeners to this program knows someone in their 80s or 90s who is cognitively impaired and who may not be able to make their own decisions. So here is a very typical clinical scenario that we see every day. Patient has a serious problem, ALS perhaps, congestive heart failure, renal failure, and is not capable of making her own decisions. The patient does not have capacity. The patient does not have agency. If there are no family members, what do we do? And that's where the social service people get involved to try to get some sense for the patient as a person, maybe from a landlord, maybe from a member of the clergy, to say if the patient could have competency, what would she tell us to do? Now, there's another dimension of this that we need to understand that serious illness, whether we're in a hospital or not, is a full time commitment. And I think it's unrealistic for a patient towards the end of life to try to continue to do what they did before they got sick. So serious illness is a full-time job. And let me give you an example. Mankato is a wonderful business community about 2 hours west of Mayo Clinic. And our family asked me to call a distant family relative who had advanced cancer of the esophagus. And I didn't know this patient. So out of courtesy to the family, I made a phone call and I received a voicemail that I wanted to share with you because it was the first kind of message I had ever heard. And basically, to paraphrase it, the patient said, "This is Bob. I cannot come to the phone. Thank you for your concern. I need to share with you I have advanced cancer. I'm in the midst of radiation therapy and chemotherapy. This is the biggest battle I've ever fought. This requires all my attention and focus, and I'm winding down from my business commitments. Please call X, Y, and Z for business relationships." So what I'm trying to say, if we have a serious illness, whether we're a patient or a caregiver, we cannot do it all, and we need someone to support and encourage us. Likewise, this businessman had considerable holdings in Las Vegas, and he had the courage to visit with his business partners and say, "Look, my health is a top priority. I cannot run these businesses and take care of myself. You're in charge. Good luck. We all have limits. There's only so much we can do." So let me tell you the rest of the story. The top photograph is a picture of the waterfront in St. Paul, Minnesota, which is about 2 hours north of Rochester. This is a turn of the century house in St. Paul, and this is the home of the Minnesota Wild hockey team. So why am I telling you this? One of our patients was a very well-respected surgeon from the Minneapolis area. And again, Minneapolis, St. Paul, about 2 hours north of Rochester. He developed cancer of the prostate in his early 50s. And we talked about end of life. We talk about quality of life. And he said, "Doc, I'm a fighter. I'm tough. I'm going to continue to see patients and operate." And we had a long talk. And I said, "Look, the radiation therapy is given Monday through Friday for 7 weeks. And all of our listeners are aware of some of the side effects of radiation. Plus, this was in November. And somewhat facetiously, as I look outside, it's like living in Siberia. It's about -5. And with the wind chill, I guess it's 20 below zero. And this surgeon told me he would be able to see patients, drive to Rochester, 2 hours, get treatment, and drive back home. So we had a long discussion, and he needed to have permission to fail. He did this for about 10 days of treatments. It did not work. He finally agreed not to practice, but to stay in Rochester for his treatment. So we have limits. We cannot do it all. And if we're going through a serious problem, we need to divest ourselves of distractions. Now, another issue that patients raise either directly or indirectly is, how long do I have? Now, patients and families understand almost without exception that we are not prophets. We don't have a crystal ball, but they can expect and they deserve some ballpark figure so they can mend fences, they can tidy up messes, They can make amends for perhaps some past transgressions. So we do have a responsibility to give them a ballpark figure. Now, if they're on hospice, by definition, their anticipated survival is about 6 months. Now, Medicare does not hold us to 6 months by the day, but that's sort of a ballpark figure. So let me share with you something called a performance score, ECOG. That stands for Eastern Cooperative Oncology Group. And all cancer people know about this. Let's suppose you or I or some other patient is in bed or in a chair for more than half of our waking hours. And this is very easy to calculate. How many hours are you in the bed or chair? How many hours are you napping? And if we are sedentary for more than half of our waking hours with a solid tumor like breast or colon or lung, the average survival is about 10 to 12 weeks. Now, to give a patient a specific timetable, it's neither fair nor reasonable. But I think patients can deserve some sort of a ballpark figure of how long they may live so they can do the homework, do the heavy lifting before their demise. But likewise, we all need to leave open that window of hope, that window of possibility, because I would think without question that every one of our listeners knows someone or knows someone who was given a dire prognosis. And that person continued to do amazingly well despite all reasonable statistical analyses. So to say to someone, your expected survival is X number of months is not fair, but I think to give them a ballpark figure is reasonable. And Hope was a small town in some area. So we all need to go through Hope before we make that final exit. Now, getting back to this racetrack theme, there was a horse called Secretariat, and arguably the greatest racehorse in the history of the game, ridden by a jockey that I was familiar with named Ronnie Turcotte. And in 1973, he won the Triple Crown as we now know it. And in 1973, I had just come on board Mayo Clinic, and I saw a patient with an advanced head and neck cancer. This was a melanosarcoma. And the Mayo Clinic record, which was typed in those days, now part of Epic, basically had the signatures of the top 3 cancer doctors in the world at that time. John Wood, he was an iconic surgeon. David Amen, head of oncology at Mayo Clinic, and Dr. Paul Scanlon, a radiation expert. And they all shared with the patient, there's really nothing we can do, go home and get your affairs in order. And I was asked to see the patient from an end of life standpoint, although we really didn't have that concept. And this is the way he looked. He had an aggressive cancer, he had lymph nodes involved, and he had a biopsy on the chest wall showing that the cancer had advanced. So I saw him every 3 to 6 months, and I never expected that he would come back. And over a 30-year period, he returned on a yearly basis. And during the first couple of years, this is what happened. And I would always ask him, well, did you get treatment at the University of Wisconsin or the University of Iowa? And he would laugh, and he had no treatment, and his wife was with him. And every time he came back, I would pose the same question. What happened? And finally, after about a 32-year relationship, here's what he shared with me. And if you remind me at the end of this broadcast, I'll tell you what happened to him as an example that we don't have all the answers, okay? This is 2003. So I want to be sure we have plenty of time. Here is my email address, cragen.edward@mayo.edu. Here is my Twitter handle, and I'd love to hear from you about different ways of sharing this information. And I'm very agreeable and anxious to address issues, questions, or your concerns. Thank you for this opportunity.
Thank you so much, Dr. Cregan, for a great presentation. Again, to the listeners, if you have any questions, please type them into the GoToWebinar control panel on your screen, and I will ask them on your behalf. A first question to get started. What do you recommend for families that do have difficult dynamics, and it might be challenging to sit around a table and have these discussions?
This is the oncologist's and palliative care nightmare, especially at the holiday season when people are fatigued, when the emotions are high, and maybe there's some alcohol in the picture. And I think having had some tremendous misadventures, the ideal way to do this is not at the bedside. If it's in a hospital setting, to find a secure, quiet room, turn off the pagers or give the pagers to somebody else. And in the meeting would be the primary care physician, would be someone like me, would be the charge nurse, perhaps the chaplain, perhaps the social worker, and other pertinent healthcare members of the team. No more than 8 or 10 people. Each member of the family would then introduce themselves. Hi, I'm Susan. I'm the patient's wife, that sort of thing. How is that person related to the patient? Then, after each of them identifies themselves, each of them would be asked one question. What do you understand about the patient's situation? And almost always, at the end of this sort of discussion, almost always, there can be a consensus of management. This takes, on average, at least an hour, and it's important to put clear guidelines up front and tell everybody we're going to meet for an hour. I then respectfully leave the room and tell the family, let's have you talk about this to yourselves. We can meet later today or we can meet tomorrow. Almost always this works. If it doesn't work, and some members want a full court press and others don't, then you get into the thorny issue of an ethics consultation and maybe a court order. These are horrible things. Almost always, if we take our time and family members are acknowledged and honored for their input, these things can be resolved in a compassionate way.
Thank you. How do you recommend going about getting a will or a medical directive? Can you do the paperwork yourself or do you get an attorney?
You really should get an attorney because there are all sorts of complex legal acrobatics that I don't know a lot about, except one thing is important. For example, it's my understanding, and maybe you can help me here, your life insurance is part of your estate. So let's assume that the life insurance benefit is $100,000, and I guess I'm parroting what I've heard from lawyers. That $100,000 is in your estate. That means it's fully taxable. If you create a trust, the life insurance is in the trust, not in your estate, and there are enormous tax advantages. So this stuff is bewildering. Get an attorney and do it right, because the decisions that are made can have devastating implications, especially if there's land, if there's collectibles, if there's farm equipment, if there's corn futures, if there's livestock. If this is not done according to the book, there can be bitterness for a generation.
Thank you. And a good resource that we often refer people to here at Fight CRC is Triage Cancer. They have a lot of
Yes.
information about that specifically. Our next question. How does Oregon's Death with Dignity Act affect these advanced directives? Is it a good law in your view?
It is a wonderful law. To die with healthy organs doesn't feel quite right. I think every one of us should acknowledge ourselves as donor organ givers when we're faced with a serious diagnosis. But in many centers, if there's a diagnosis of cancer, that may well disqualify a patient from providing an organ for someone who may need it. So I think almost always there are local nuances for organ donation. Now, I want to be certain I answered that question. Please go back. I want to, because this can be a controversial area.
Sure. So, how does Oregon's Death with Dignity Act affect advanced directives? Is it a good law in your view?
Okay, tell me what the person means by death with dignity, because it means different things in different states.
So, I'm not sure, perhaps just the talking about the act in and of itself, just the
Are
concept
you
of it.
refer, are you referring to physician assisted death or physician assisted suicide?
Ah, um, I believe this person might be talking about this specifically. I will clarify, but if you can go down that road for now, and if he changes it, then I will let you know.
Well, I think, boy, this is why these sorts of dialogues are so important. I honestly don't know. I'm not familiar with how this is handled. That if someone um, participates in physician-assisted suicide or physician-assisted death, can they be an organ donor? I don't know, but I will certainly find out. And if the writer of that question emails me, I will have an answer. But I honestly don't know. That's a wonderful question.
Yeah, so it looks like they were discussing a physician assisted. So I know there's a lot of controversy around that, and maybe we don't know yet how it plays out.
Yeah,
In
I don't know. I can certainly access some of the ethical legal experts, but I've never been posed that question, but I will find an answer. Thank you.
So talking about death tends to be something that is avoided in a lot of cultures, and how do you um, recommend addressing it if it's culturally challenging?
Ah, that's an important question. At Mayo Clinic, we have guests and visitors throughout the world with belief systems and cultural foundations very different from many of us. And what I have learned, painful lessons, is to go to the responsible member of the family. Usually it's a son, sometimes a spouse, and ask them, in your culture, what is the appropriate way to handle this problem? For example, for some of our patients from the Middle East, the concept of cancer is anathema. This is not an appropriate term to use for fear that the patient will give up hope. And it's a term which is rife with misunderstandings. So when the family tells me and my colleagues that we should not use the word cancer, we honor that culture's wishes and do not mention it. We talk about a process, we talk about a shadow, we talk about an abnormality, we talk about the seriousness of that abnormality, we talk about treatment, but we deliberately do not mention the word cancer. Likewise, in some Asian cultures, patients are never specifically told that they have a diagnosis of cancer for fear that they would give up or have some emotional issues. So we honor that family's wishes. And I'm never aware of any sort of legal implications from honoring the wishes of the family in those circumstances.
Thank you. What role will the hospice care team take in terms of end of life care and advanced directives and wills? Do they play any role in that for a patient?
The key role of the hospice is to provide quality of life and sense of well-being from an emotional and a spiritual and from a psychological perspective. And we cannot divorce pain management and anxiety management from recognizing the importance of appropriate legal and financial planning. So if there are all sorts of legal loose ends, if there are some financial pieces that need to be addressed, I think the hospice is well positioned to at least raise the issue. Mr. Jones, we're doing everything we can to keep you comfortable. Where are you with any estate plans? Where are you with your banker? And I think these can just be generic questions that trigger action on the part of the patient and the family.
Thank you. At what age do you recommend someone creates an advanced directive? So I believe this question is just broader than someone who's been diagnosed with cancer, but just for the general public, at what age would you recommend?
Wow, these are tough questions. You know, I thought I knew everything, but these are wonderful. I'm just guessing that the age of majority in most states is 18. So I would think that at age 18 and older, that person, if they have capacity, can write up a will and advance directives. Now, let's suppose the patient is 14 or 15 and they're very mature. I believe the parents would still have the legal responsibility to honor advance directives. But I think 18 is the magical age after which that patient would be responsible for their own advance directives.
Thank you. We're out of questions. Does anyone have any additional questions or comments that you'd like to make at this point? Um,
Sharon, would anyone like to know the story behind that patient whose cancer disappeared?
yes, I would. Yeah, that would be great. Thank you.
Okay, here's what happened. This was Pearl Harbor Day, 1973, when he was diagnosed. And he was basically told by the three top cancer people in the world, head back home, nothing we can do. And over a number of years, the cancer disappeared. And I would ask him with each visit, what happened? And he would be almost embarrassed and never tell me. But then one day, his wife said, okay, tell Dr. Cragen what really happened. So just picture this. You've come to the Mayo Clinic. It's in the middle of winter, and you were told there's nothing we can do. He was devastated. He was bereft of hope. He walks out the front door of the Mayo Clinic, and the first building he enters was a church called St. John's the Evangelist. And again, it took him 32 years to tell me this. He walked into the church, he's sitting in the pew, and he said his tears were bouncing off the marble floor. He was totally despaired. He had the sense of someone coming up on his left side, the side with the cancer. He quickly turned to his left side. Now, again, 32 years to tell me this. There was a small, shawled woman, maybe 5'2". She put her hands on his neck and basically said something to the effect, hang in there, keep the faith, it's going to be okay. A nanosecond later, his wife comes up on his right side, the side without the cancer, turns to her and says, Ethel, I want you to meet someone. He turns to the left, boom, that creature was gone. Now, he didn't make this up. He was embarrassed to tell me this. Now, I don't know what happened. I don't know what this being was, but I do know that after that relationship, his cancer disappeared. And every one of our listeners knows someone who had a reprieve from a serious problem. And I've always asked those patients, what was it that gave you a reprieve from this problem? And in every case, it was the power of a relationship, even a dog or a cat. It wasn't to have a bigger boat or a bigger franchise, but it was that a healing power of a relationship that was the catalyst for restoration and community. So that was the end of the story, Sharon.
Thank you so much. And those are some really powerful words to end on. The power of community and connection are so important, I think, for everybody. And while it's important also to plan for these end of life for everybody. I know you mentioned it earlier to keep hope alive and to keep connections growing and strong. Those are really important and really vital to our lives. So
Yes.
thank you so much, Dr. Cragen, for your time and for your expertise. And it's been a really wonderful presentation. Any final words for
Thank you.
our listeners today? Any final words for our listeners today, Dr. Cragen? Or
Yes, the final word, pick up that phone, send that email, couple of words. I'm sorry, I love you, I forgive you, please forgive me. Wow,
thank you.
that's great. Be safe out there. Thank you.
Thank you. Thanks to all the listeners out there. Have a wonderful day.
Thank you. Bye-bye.